non-invasive genetic prostate cancer diagnostics. We have medical biologist Gagilas and from molecular diagnostic laboratory Diagnostics. So please, you can start.
Okay, thank you very much. Good morning, everyone. I'm Julius Gagilas from company Diagnostics, and I will speak about non-invasive genetic prostate cancer diagnostics. And the plan of my presentation is, first of all, introduce to liquid biopsy, then to speak about molecular diversity of prostate cancer. Then I will speak about available urine tests for prostate cancer diagnostics, and I will finish with conclusions. Liquid biopsy is an alternative to tissue biopsy, and the idea is that you analyze body fluids such as saliva, plasma, or urine, or others, say milk or tears, and you look for foreign biomarkers. It can be cells or molecules, and information from these biomarkers can say you about the foreign cells in body. And liquid biopsy is widely used in reproductive health, cancer, and transplant medicine. So in case of if you analyze tumor, you have some cancer applications, cancer diagnostics, or you can check therapy and so on. In case if you have pregnant woman and you have fetus, so you can have non-invasive prenatal diagnostics. And in this case, it's very, from diagnostic point of view, it's very similar to cancer, but with happy end. You have the same situation. You have foreign cells, and you can detect information about these cells in body liquids. And also, when you have transplanted organ, you can have applications to check how this organ is behaving in body. So then tissue is an issue, so then liquid biopsy helps. What kind of biological material can be analyzed? So when you have a tumor, so this tumor can shed into body fluids different things. First of all, it can be cells, so-called circulating tumor cells, which go into say blood or any other liquid and traveling, and these cells are quite easy to isolate. The maybe only problem is that there is a quite small number of these cells available. You can have from few cells to tens of cells per milliliter of blood, say, and some advanced technologies are needed to separate these cells. But nowadays there are new technologies which can easily isolate these cells. Second thing that exosomes are small vesicles which are produced by healthy cells and also by tumor cells, and usually tumor cells they produce much more exosomes. And in body fluids we have huge amounts of exosomes. It can be from tens of thousands, hundreds of thousands, and millions per milliliter of body fluid. And also circulating nucleic acids, such free DNA or different kinds of RNAs, microRNAs, mRNAs, long non-coding RNAs also can circulate in body fluids. And if we analyze body fluids, we usually these nucleic acids we get from exosomes and from cells and from all the material. And once we take this liquid biopsy, we can apply it for cancer diagnostics, for metastasis detection, population screening, monitoring of disease progress, and response to therapy. And if to compare liquid biopsy to tissue biopsy, liquid biopsy is minimally invasive, and also it represents tumor heterogeneity. It is easily repeatable and reproducible. You can take samples every day or a few times a day and monitor disease quite easily. There is no complications possible. Maybe some problematic things are that currently still there is a need for standardization, and these technologies mainly still are used in research. And when you get some information, still it is not possible to have histotype specification and staging. You see, tissue biopsy, you can easily say what stage of cancer is. Okay, so in 2015, there was a publication where scientists analyzed more than 300 primary prostate carcinomas, and they realized that there are 7 molecular subtypes of prostate cancer. And you see in the picture, in the first graph, the largest portion of cancers fall into ERG positive subtype. It's about close to 50% of prostate cancers. They contain so-called ERG fusions. Under this group, you see there is a ETV1, that's a fusion group, which is a smaller number, also ETV4 and PLI1. All these fusions are so-called ETS fusions. So about 50% of cancers, they contain any of these fusions. Also, it's about 11% of tumors have SPOP mutations, and very interesting thing is that these tumors which have SPOP mutations, they do not have these fusions. So it's quite separate group of tumors. And also there are 2 small groups, FOXA1 and ADH1 group. And all these 7 groups of cancer, we contain about 74% of all tumors. And the remaining 26% of tumors, they do not fall to any other group. They are not classified. So from point of view of diagnostics, so if you have some biomarkers, still you have quite large group of cancers which would not be represented with any biomarkers, genetic biomarkers. And so according to molecular profile, prostate cancer can be classified to ETS fusion positive. It's about 50% of all possible cancers. To the right side, you can see that this group contains the main fusion is TMPRSS2 ERG fusion. It's about 90% of all fusions. And in this group, you can often find tumors with TP53 mutations and 10 deletion. And in the left side, you can see that about 10% of prostate cancers we have is SPOP mutations. As already mentioned, these do not have ETS fusions. and a quarter of all prostate cancers were unclassified, and because of this high diversity, there is no universal biomarker for efficient diagnostics. So you should have some combination of few biomarkers if you want to have effective diagnostics. And if to talk about gene fusion, so the main fusion which is found in prostate cancer is TMPRSS2 ERG fusion, which can be found in 50 to 80% of prostate cancers, and it is almost not detected in any other cancers. And also it is found in not only in case of cancer, also in HPIN, and it is suggested that this fusion plays a role in development of prostate cancer. And then good thing is that these fusions can be detected in urine and can be used in early prostate cancer diagnostics. And in the right side you can see a picture which represents how this fusion happens. We have these two genes, TMPRSS2 and ERG, which are separated from each other by 3 million nucleotides, and when this rearrangement happens, ERG comes to TMPRSS-ERG, and the result is that ERG protein, normally there is not present in high amounts in cells, starts to be generated in cell in high amounts, and so it, and this is a reason why prostate cancer is developing. So not only genetic, biomarkers are available for cancer, also so-called epigenetic biomarkers also are available, so-called long non-coding RNAs, which are not coding for protein. These are available in case of prostate cancer. And on the right side you see picture about some regulation mechanism, but I presenting this picture just to show that there is a large number of different long non-coding RNAs which take part in prostate cancer. And one of the first biomarkers, it's PSA3, which was discovered in 1999, and it was shown that this biomarker is expressed and has increased expression up to 100-fold in case of prostate cancer, and this enhanced expression enhances AR signaling, cell growth and viability, and also regulates expression of other genes. And this biomarker was approved by FDA as prostate cancer test in 2012. If you combine PSA3 and the fusion gene TMPRSS-ERG, you can increase specificity of prostate cancer diagnostics. And the good thing that these biomarkers can be detected in urine, and you know very well that urine for many years is being used as for diagnostic tool, and it is also expressed in paintings, how doctors in Middle Ages just looking to urine and doing diagnostics. Nowadays, urologists can do liquid biopsy test using urine samples and check for molecular biomarkers and have information, genetically based information about the disease. So Here is a list of available urine diagnostic tests for prostate cancer. In Diagnolita, we have tests which measures PSA3 and temperature ERG biomarkers. Also, similar tests are MIPS test with the same exactly biomarkers. Also, exosome diagnostic test which measures PSA3 and ERG genes, and use different reference gene, it's SPDF. In addition to these biomarkers, also clinical information is used, and most of these tests, according to recommendations, are recommended for patients which have PSA from 2 to 10 nanogram per milliliter. Also, some tests needs prostate massage before taking urine sample to increase the amount of biomarkers in urine. The exosome diagnostic test is only without prostate massage. Diagnolitas tests can have both options, with prostate massage or without. And so the test is performed like taking urine sample, measuring PSA3, temperatures ERG, and PSA messenger RNAs. Also use standard clinical information, age, prostate volume, and PSA, and then calculate probability of prostate cancer. And it's very important because it's liquid biopsy and amounts of markers are very low in the samples. So there is a need to have a high volume of sample. And we use special device for urine collection. You can see in the picture on the left side. This device allows to collect very first fraction of urine, and very first fraction of urine contains highest amount of biomarkers which come from prostate. Next thing, in this device we put stabilization solution, and when you urinate, so instantly urine mixes with this stabilization solution, and you have biomarkers stabilized from very beginning until they traveling to laboratory. So when you get sample into laboratory, it's important to have efficient technologies to purify nucleic acids. So on the right side you see a picture which presents efficiency of our purification technology. If you buy kits which are used for nucleic acid purification from companies like Norgine Zymo Research, you can purify nucleic acids, but yield is quite low. Our technology allows few-fold more yield of nucleic acids from urine sample. So when you have efficient technologies, then you have very sensitive methods, and you can detect efficiently biomarkers even without prostate massage when you collect urine with lower amounts of biomarkers. And the result we provide for patients and doctors, so it's a probability or likelihood of high-grade prostate cancer, and total likelihood of cancer. So on the left side, we see an example of a result where high-grade prostate cancer likelihood is low. On the right side, when we have very, very high probabilities of high-grade cancer. And how to know if the test or biomarker is good or no. In 2019, there was a publication of so-called San Francisco consensus statement, and which says that any biomarker or test must be shown to add value on existing multi-variable clinical standard. So you must show that marker or test adds you something on addition on existing clinical information. And we did analysis for our test and test of other companies from data available on publications, and compared this added value to the test. So this orange bars shows in each case what is the diagnostic performance of clinical information. With AUC, it shows shows diagnostic performance, and you can see that in all cases we have this AUC about 0.63, 0.65. Only in case of SelectMDx test it is 0.7, and diagnostic performance of whole test is higher, and the difference between this AUC shows added value of the test. And these added values is statistically significant. You can see p-values above the bars, and we are happy that our test shows really highest added value to the clinical information. And I would like to conclude that liquid biopsy is an alternative to tissue biopsy, which allows to screen, diagnose, monitor cancer by detecting biomarkers in body fluids. Prostate cancer is genetically very diverse disease. Therefore, combination of biomarkers is needed for precise diagnostics. And combination of PSA3 and TMPRSS2 ERG biomarkers allows precise early prostate cancer diagnostics. And I would like to finish with this map of prostate cancer diagnostics. As you can see, that most prostate cancer tests are being developed in United States, and we are happy that we have also in Lithuania. And I know that smart scientists are working in Vilnius University and National Cancer Institute, and I hope that we will have new tests available on this map. So thank you for your attention.
Thank you for the presentation. Any questions? Any questions? We have a question from Professor Yermalite, please.
Thank you very much for this nice presentation and for the knowledge that we have some useful information even in our urine. So my first question is, in what cases clinical doctors send patient or patient's urine for your Diagnolita test? And my next question will be about the future. Maybe for the future you are planning expand your panel and to have polygenic risk biomarker test in urine. Thank you.
Thank you very much for good questions. So first question, with liquid biopsy urine test is usually done in cases when it is not clear if to do biopsy or not. Then PSA is elevated between 2 to 10, as you probably everybody knows that PSA can be elevated due to different reasons, especially when you have 3, 4, or 5 up to 10. And there is no signs of prostate cancer, but still patients are worrying about prostate cancer. And also it is clearly said in guidance for urologists that with such a test are recommended when DRE test is normal and PSA from 2 to 10. And next question, yes, we are doing research and looking for new biomarkers, and we're collaborating with National Cancer Institute scientists, and we hope that we will find additional biomarkers which will allow to increase specificity of the test, and that patients could have more precise diagnostics from urine, and that we could do the test at home, just urinate, send sample to laboratory, and get the results.
Thank you very much for your answers.